Hello viewers, I'm Dr. A. Arif Yezdani, Professor and Director in the Department of Orthodontics and Dentofacial Orthopedics. I'm here again with yet another topic in orthodontics, namely TADs in orthodontics, meaning temporary anchorage devices in orthodontics. This is a voluminous topic and I shall be dividing it into 4 parts. Part 1, Part 2, Part 3 and Part 4. Part 1 would be dealing with the definition of an implant, a mini implant, a micro implant, parts of a micro implant, as also the parts of insertion. So to get going, at the outset, we would like to know what is anchorage. Anchorage is the nature and degree of resistance to displacement offered by an anatomic unit when used for the purpose of effecting tooth movement. Now, anchorage can be got from different parts of the head. We can use the anchorage from the occipital bone, the parietal bone, the neck region, and hence we term this as the occipital headgear, the combination pull headgear, the cervical pull headgear. We can also use the anchorage from the forehead as also from the chin in the use of the petite face mask, which is used for the correction of a retrognathtic maxilla and a slightly prognathic mandible. We can also use anchorage intraorally, known as the Nance holding arch, and if an acrylic plate is placed in the front, then it adds more to the anchorage. We have the transpalatal arch, which is a sort of a omega loop between the 2 molars, and in the case of the mandible, we can use the mandibular lingual arch. But then, as we all know, the Newton's third law of motion, every action has an equal and an opposite reaction. So we want an anchorage which is absolute, which doesn't move. And hence, we have now come to that scenario where we are in the use of TADs. Now, what we mean by a TAD, it is a temporary anchorage device, and according to Cope, is a device that is temporarily fixed to bone for the purpose of enhancing orthodontic anchorage, either by supporting the teeth of the reactive unit or by obviating the need for the reactive unit altogether, and which is subsequently removed after use. So what we desire right now would be absolute anchorage and anchorage which does not move. You need to have a minimal surgical invasiveness of the procedure. There should be good versatility, and of course, it should be of a low cost. So it was Kenomi in the year 1997 who introduced the surgical mini screws for orthodontic anchorage, and it was in the year 1999 when Sugawara introduced the skeletal anchorage system. So the nomenclature. So we would first like to know what is an implant. Any foreign object when retained in the human body for more than 1 month, it is known as an implant. Then when do we call it a mini implant? When the diameter of the implant is greater than 1.9 millimeters, we call it an mini implant. The length could be 10 to 14 mm, or it could be also 8 mm as the case may require. When do we call it a micro implant? When the diameter of the implant is less than 1.9 millimeter. And here too, the length could be 11 millimeters or 6 to 8 millimeters. So what are the parts of a micro implant? We have the head, we have got the neck, and we have got that portion, the screw portion, which gets drilled into the bone. where the tip is sharp, and we call it as the self-drilling tip or the gimlet. So a microimplant is an alloy of titanium, aluminum and vanadium, whereas the bone screws, which I shall be dealing with at a later time or a later date, would be stainless steel. So what are the factors which affect the microimplant size? The length, diameter, shape, path of insertion, which could be perpendicular or diagonal, soft tissue thickness, bone quality and anatomical limitations. We shall get into the details of all these in a short while. So what are the indications? It can be used for uprighting the molars, for segmental retraction, for intrusion of a single tooth or a full arch, for protraction of teeth, for full arch distalization of maxillary and mandibular dentition, and for distalization of arches in retreatment cases of anchorage loss. So then we need to know what is the bone density in the maxilla and mandible. So Mish has classified the bone densities into D1, D2, D3 and D4. Now when you look at the anterior maxilla, you see the green vertical bar, that is more so D3, where the cortical bone is little less at the dense trabecular bone. Then if you see the posterior maxilla, of course the D3 is also present there. But when we see the anterior mandible, it is blue, where the cortical bone is more thicker. And then when you look at the posterior mandible, there is a combination of a D2 as also a D3. Here, the cortical bone is little more thicker. Then where do you find this D1? In some instances in the anterior mandible and in some other instances in the posterior mandible. Length of a microimplant. So as we all know, microimplants have to be inserted into bone. So to what length should they be inserted? 6 millimeter. Of course, longer microimplants are required in maxilla because, as you know, the cortical surface is thinner and less compact and we have more of cancellous bone. Now, when it comes to the mandible, the portion of the screw which should be in the mandible should be at least 5 millimeters. Buccal surfaces and retromolar areas offer adequate thickness and high quality cortex. Diameter. The APSO anchor system uses numbers to describe implant sizes. So when we say a number 12 series, we mean a 1.2 millimeter diameter. When we say number 13 series, we mean a 1.3 millimeter diameter. It is used for orthodontic forces of up to 300 grams. Now when we say it is a 14 series, of course it is a 1.4 millimeter. Then we also have the 1.5 millimeters as also the 1.6 millimeters. These are all used for forces between 300 and 450 grams. And these are used when you want to move the entire mandibular dentation distally or the maxillary dentation distally. So when you use a number 17 series, which is a 1.7 mm or a 1.8 millimeter length microimplant, they are used for intermaxillary fixation during orthognathic surgery. So larger diameter implants we don't use more than 2 because we know that they're going to osseointegrate, and in orthodontics we do not want the microimplants to osseointegrate. So what is the path of insertion? The size of a microimplant is dependent on the path of insertion. So there are 2 types of insertion, namely a diagonal one or a perpendicular one relative to the cortical bone. So when we say a perpendicular direction, we mean that is the ideal. Now can we achieve this? We shall discuss about this a little bit later. So a diagonal direction is desirable in certain cases because it avoids injury to an adjacent tooth root or other anatomical structures. So longer and wider microimplants to be used since a portion of the microimplant is not covered by bone. So that's the reason we require a longer one, and so that it goes diagonally and you have enough thread length for it to get into the bone. So it is inserted at an angle of 30 to 60 degrees to the long axis of the teeth. So the manual insertion in the maxilla is either 90 degrees, as you can see on the left side, or on the right side, if you see that particular figure, it could be in a diagonal direction. And in the mandible too, it's the same. Either it is at 90 degrees or at 45 degrees. So what is the importance of proper angle insertion? We require cortical anchorage, patient safety because the tooth roots are pretty close to each other. We require good biomechanical control, and we need to reduce the risk of damaging the dental roots of the adjacent teeth, and to provide increased surface contact area between the microimplant and the bone. Now we have spoken about so many types of parts of insertion. Okay, and in the insertion we said it could be 30 or 45 or 60 or 90. So we did a small study where we analyzed the stress in the bone and in the microimplant during en masse retraction of maxillary and mandibular anterior teeth with different insertion angulations. This was a 3D finite element analysis study. This was published in the American Journal of Orthodontics and Dentofacial Orthopedics in the year 2012. So what did we actually do here? So the objectives of our study at that particular period of time was to generate a finite element model of the maxilla, the mandible, and the microimplant to simulate orthodontic loading of about 200 grams for en masse retraction and to evaluate the von Mises stress patterns in the bone and the microimplant immediately after loading with different insertion angulations of the microimplant such as 30 degrees, 45 degrees, 60 and 90. So we would like to know which is the best insertion angulation. So for this, we made an FEM model of the maxilla and the mandible with extracted first premolars. We had the PDL, the alveolar bone, etc., all being FEM. So we took certain specifications for the teeth from Wheeler, for the facial access point from Andrews. For the buccolingual inclinations, we used the Kim et al. And then for the maxillary and the mandibular dentition, so far as the Roth is concerned, we used the true arch form, which is of medium size. And then we used the PDL specifications from Cronsfield and Coolidge, and we all know that the PDL width is about 0.25 millimeters. The pre-adjusted edgewise arch appliance was used, and the slot was 0.018 into 0.025 inch. And we used a stainless steel arch wire of the dimension of 0.016 into 0.022 inch rods. And we used 4 power arms and the NITAC coil springs, which could produce a force of about 200 grams on either sides. And the micro implants were placed, for example, about 5 to 8 millimeters from the alveolar crest, so far as the maxilla is concerned, and 11 millimeters from the alveolar crest, so far as the mandible was concerned, according to the specifications of Pogoyo et al. So the FEM did have its linear elasticity, the isometric properties of the same quality. We had the Young's modulus and Poisson's ratio for the teeth, PDL, bracket, wire, all from specifications from Walmer et al. And Raymond et al. We had the Young's modulus and the Poisson's ratio for the trabecular bone. Now I said we used the maxilla and the mandible, so we also tried to simulate the type 3 density type of bone for the maxilla and the type D2 for the mandible. So as we all know, the type D3 in the posterior maxilla means one with a thin layer of about 1 millimeter of cortical bone surrounding a core of dense trabecular bone, and the type D2 was in the posterior mandible with a thick layer of about 2 millimeters of compact bone surrounding a core of dense trabecular bone. And of course, all the other specifications we did take into account, namely the 3D quadrangular and the hexagonal elements for the tooth and the standard edgewise bracket models. And then so far as the PDL is concerned, we took the thin shell elements and the archwise, the 3D beam elements. And then so far as the implants are concerned, we made an FEA model of the APSO anchor micro implants, and if you see here, we used the 1.3 millimeters diameter and a length of about 8 millimeters for the maxilla, and the 1.3 millimeter diameter and 7 millimeter length for the mandible. And these implants were simulated according to the specifications from Dentos, Daegu, Korea. And then how did we actually analyze and evaluate the von Mises stress, for which we made a bone block, which was our model for the study. And this bone block was about 8 millimeters in height and about 14 millimeters in width and about 10 millimeters in depth. So far as the maxilla is concerned, we placed the micro implant between the maxillary second premolar and the maxillary first molar, and so far as the micro implant concerned for the mandible, we placed it between the mandibular second premolar and the mandibular first molar. So the stress distribution and the magnitude was analyzed by the ANSYS workbench, which is a 3D FEM analysis program, version 11 from Pennsylvania, through a bidirectional understandable translated system called Initial Graphics Exchange Specification. So then, what were our conclusions? So when we compared the von Mises stress, we found that the comparison of the maximum von Mises stress in the micro implant showed that as the insertion angle increased from 30 degrees to 90 degrees, the stress decreased. And when we compared the maximum von Mises stress in the cortical bone, it also showed that as the insertion angle increased from 30 degrees to 90 degrees, the stress decreased. And the comparison of the maximum von Mises stress in the cancellous bone showed that as the insertion angle increased once again from 30 degrees to 90 degrees, little stress was transmitted to the cancellous bone. And a fourth conclusion was that in the analysis of the maximum von Mises stress, according to the bone quality, stress was higher in type D3 bone quality, that is in the maxilla, than in the type D2 bone quality, that is the mandible. So we finally concluded that micro implants should be placed as perpendicular to the bone as possible for better stability. But then every clinical scenario is different, so we need to understand that, and in order to avoid injury to the tooth roots, we may also have to place it a little bit diagonally. So that is left to our perception and after having understood the clinical scenario. So dear viewers, I shall just conclude right now the first part of my TADS in orthodontics presentation, and we shall go on to the other details of the TADS in orthodontics in part 2. Thank you all so much.